Hello everyone, myself Dr. Sheeta. Welcome to my YouTube channel Miss America. I'm here to help you and guide you for your upcoming examination INICET November 2022 and NEETPG 2023. In the last video, we already discussed about the 5 questions of the first 8 of embryology, and in this session we will continue the further 5 questions of first 8. I'm not taking too much of time. Before that, I want to tell you about only 2 things, that please do like, share and subscribe my channel, and also inform other people so they get help from this video. Second thing, I will try my best to completely speak in English, to make this lecture in English, but still forgive me when I will use to Hindi languages some kind of words, because it's my tongue language, mother tongue language, and I'm become habitual for Hindi. So let's begin with this question. Before starting the question, let me tell you one thing. As in the last video, I will starting from the last line. In this session, I am going to start from the last session. But remember the one thing also, that it is not necessary from that reading the last line you get to hold the answers. Sometimes we have to read the complete questions, okay? But still, we are going to discuss from the last questions when it is from the last line. When it is the lengthy questions, and then we are discussing about the options, and then we will going back to the questions. So let's begin with the first question, that is question number 6. What is the probable source of the child's condition? Okay, that he is asking about right now the clinical scenario is given about the child and from which condition he is going through. First option, blockage of the intestine due to folding of the distal ileum into the proximal colon, suggesting of intussusception. Let me write it here. Intussusception, right? What is saying in this language? I already read it. Okay. This is the proximal colon. This is the small intestine of part which is moving inwards. Imaginate हो रही है, okay? Second statement is about to which topic? Let's see. The second statement is saying that break down the stomach mucosal barrier with the erosion of the underlying mucosa, suggesting of the peptic ulcers, because in peptic ulcer there is the breakdown of the mucosal layer of the stomach. Peptic ulcer. Okay. The third option is suggesting of damage to the intestinal epithelium due to ingestion of the coins, means due to the foreign body ingestion. Okay, due to the foreign body ingestion. The fourth statement is saying about ectopic gastric epithelium in a persistent omphallomesenteric duct. Omphallomesenteric duct, suggesting of also known as vitellointestinal duct. Vitellointestinal duct becomes remnant, and there is ectopic epithelium also. So it is talking about the mucus diverticula. Got it? And the last option is incomplete bowel rotation resulting in obstruction of the superior mesenteric artery leading to the superior mesenteric ischemia. And malnutrition. Okay. Now these are the motor diagnosis हमने बना लिया. These are the diagnoses which made by us, that this is statement saying this thing, this is statement saying this thing. मतलब we are read about intussusception, peptic ulcers, foreign body ingestion, mucus diverticulum, malrotation and superior mesenteric ischemia. Sorry for बच्चों की आवाज़ है ना, बच्चा लोग भी खेलेंगे तो सही ना, ऐसा थोड़ी ना छुट्टियाँ चल रही है. Okay, don't worry, I am not saying anything important. I just think sorry for the hindrance about because of the children's voice, but this is their vacation time. They are going to enjoy all this time. Let's begin this question from the starting. 13-month-old child. 13-month-old child. First one is because many times the age is important factor to rule out the diagnosis. 13-month-old child is brought by the parents in the emergency room because of finding blood in the stool. Blood in stool यानी कि per rectal blood आ रहा है. Second point. Third point is suggesting of the pressure, tenderness. ठीक है. Abdominal pressure, because by applying abdominal pressure there is tenderness, otherwise there is no tenderness on the third point. And the fourth point is during investigation is done by technetium 99 per technique. This is the most important point, and because technetium 99 per technique is used for detection of the blood. It can detect 0.1 ml of per minute of the blood, and it is the investigation of the choice for Meckel's diverticulum, right? So my answer will be going towards the Meckel's diverticulum, because let's read about the Meckel's diverticulum from my notes, or let's from the notes first. This one interception. Okay, fine. I did not keep my notes here for Meckel's diverticulum, so we will going from my handwriting notes. ठीक है, तो मेरी handwriting बेकार है. My handwriting is worse still. Meckel's diverticulum, because Meckel's diverticulum is very important. It asked 2 times in the aims. Okay, INICET में 2 बार पूछा गया क्वेश्चन है. What is diverticula? First thing is important, that what is known as a diverticula. Diverticula is of 2 types. That is a protrusion of the intestinal epithelium. This is the lumen, not intestinal epithelium but intestinal layer. These are the layers of intestine. This one is the lumen. These are the layers of intestine. 2 kind of a protrusion we usually see in that. First, where all the layers are protruded, and the other where only इंटेस्टाइनल मिकोजा और इनरमोस्ट लेयर जो होती है वो मिकोजा होती है, वो प्रोट्रूड हो रही है. ठीक है, एंड द इनरमोस्ट लेयर्स ऑफ द मिकोजा प्रोट्रूड्स एंड फॉर्म अ पाउच लाइक स्ट्रक्चर. दिस इज नोन एज द डाइवर्टिकुला. So what is Meckel's diverticula? Meckel's diverticula, first important thing is true diverticula. It develops from the because of the remnant of the omphallomesenteric duct or vitalointestinal duct. ठीक है, these are the 2 most important point. Then third point is that most common congenital anomaly is seen in the male child more commonly than the female child. And the rule of the 2. What is the rule of the 2 saying? Less than 2-year-old child seen in less than 2-year-old. तो क्या था जो हमारा कंडीशन क्वेश्चन था, तो क्वेश्चन में क्या था? द क्वेश्चन इज सेइंग दैट देयर इज अ 13-month-old चाइल्ड. ओके, तो इट इज़ लेस देन 2 years old ना, तो रूल ऑफ 2 इज अप्लाइंग हियर बाय सेइंग दैट लेस देन 2-year-old चाइल्ड विद इन द 2% ऑफ द पॉपुलेशन. Meckel's diverticulum will be seen in the within the 2% of the population and 2 inch long and 2 feet proximal to the ileocecal junction. Okay, 2-year male child, you can say this. देखो, let's again first go back to the question. We are finding that there is an ectopic gastric epithelium. there will be reason, no? There will some reason why this is the no tenderness and still there is the bleeding. Okay, while in intussusception there is lots of tenderness, lots of the pain to the child. He can't bear this pain. Got it? My point. To here, by applying pressure, there is a tenderness. Something is suggested there will be no tenderness. Okay, sorry, there will be no pressure, no pain. Only pain when during the pressure is applied in the diverticula. Here in the question, while in intussusception, what is going on? While in intussusception, the pain is present throughout. Whatever you want to give, like you want to give the NSAIDs, high dose of the morphine, he can't get any kind of a relief. He relieved by some 1.5 to 2 hours. You need to give sedation, but then you realize the pain is not going because of the ischemia is going on in its intestine. Okay, but here, bacha normally, the baby is not crying here, the baby is not crying on the food and anything else, and still there is a bleeding per rectum, there is a mild tenderness, and this is because of the erosion of the mucosa. And erosion of the mucosa is happen when there is gastric epithelium, because gastric epithelium secretes HCl, which erodes the mucosa because of its acidity in nature. Okay, so there are most common two types of mucosa is found because it is known as heterotropic. What is the meaning of the heterotropic mucosa? Is that the location, like stomach mucosa है, stomach layer है, so it will found only in the stomach. Pancreatic, it will found in the pancreatic, but it will found somewhere else, known like something is ectopic presence, like है ना. So this is known as a heterotropic mucosa, and most commonly found two type of mucosa, that is pancreatic colon and gastric kind of a mucosa. This gastric mucosa will leads to the bleeding because of, wait a minute, bleeding by rectal. Okay, why? I told you, na, acid secretion increase in H plus, less of mucus barrier, will erodes and will leads to the bleeding per rectum. And sometimes we found that there is peptic ulcers and perforation happens, so it can also leads to the perforation. And when there will be perforation, it will leads to the peritonitis. Okay, yes, kindly understand this topic. Megas diverticulum is very important, and this one is the clinical scenario of the megas diverticulum. Okay, I told you that the investigation of choice for megas diverticulum is technetium 99 per techne, because its RBC scan here. So investigation of choice is technetium 99 per techne, 0.1 ml of per minute of RBCs, meaning blood loss. This kind of a blood loss, this much amount of the blood loss can be detected by the technetium 99 per technet scan, and this will also asked in the AIMS. That's why there is many questions from this topic, and that is the reason that this topic is very important. What is the treatment? The treatment is this, that we need to do surgery, and with surgery there is a two option, that we can do diverticulectomy, that is removal of the diverticula, or we can do this to resect the two part of the intestine and anastomose it. With this, diverticula also remove. Why this is the reason that in some patients we are going to remove only the diverticula, while in other patient we are removing part of the intestine. This is the reason when you find gastric epithelium, and it will leads to the bleeding. When you find the gastric mucosa at the neck of the diverticula, it's not the problem now when gastric epithelium is found here, so you can easily cut and remove it. But when you find the gastric epithelium here, Okay, so what will happen? There are chances that some part of the epithelium will remain here, and it will further increases the risk of the bleeding. So we will what we will going to do, we will remove the proximal part. We will going to remove this proximal part and then anastomoze it. Okay, usually we do not do surgery in elderly patients because it increases, the surgery can also increase the morbidity risk. That's why we avoid in elderly patients surgery. Next option. Okay, this is the answer. Let's see intussusceptions. Let's read about it. Class. Intussusception. Sorry. So I hope it is clear to you. कोई बात नहीं, I will explain it on making notes on that. Okay, let's start. Intussusception में क्या होता है? There is invagination. I told you that there is invagination. The part which invaginates is known as the donator part. Okay, the parts, suppose this is my small intestine and this is my colon. Cecum वाला part है. This is the proximal part of the colon and this one is the distal part of the intestine, and it invaginates in this part. Okay, this part is known as the donator part, and this one part is because it's receiving, it's give some part, that's why it's known as a donator, and it's receiving this part, that's why it's known as a receiver part. Okay, the point where it starts to invaginate, it's known as a lead point. Okay, most common type is ileocecal type होता है, other type it can be ileoileal type, colocolic type हो सकता है. That means it can be like this. These two ileum and can invaginate in between them. Colon part, ठीक है, तो colic part है, which is most commonly seen in the adults. Most common जो leak point होता है, because there is chances of the intussusception in the Meckel's diverticulum also, and in children because of the Meckel's diverticulum, this is the leak point. Okay, this is a lead point in the children's having Meckel's diverticulum, and adults there are chances of because of the polyp formation may be due to the hypertrophy of the lymph nodes and anything else, because of the familial adenomatosis polyp, which can leads to the invagination and leads to the obstruction. Next page. ठीक है, तो intussusception is the most common cause of the intestinal obstruction in children more than 6 months, not less than 6 months, it is more than 6 months. Okay, what is the causes of what are the causes of the intestinal intussusception? I told you that some parts will hypertrophy, pair patches are found in the intestinal epithelium. Mostly the highest amount of the pair patches is found in the colon part because of the lymphoma, because of the viral infection. Why is viral infection? Viral infections, it will alleviate the number of the T lymphocytes. ठीक है, तो there are the pair patches है. The function of the pair patches is to create immunity. This is known as a maltoma, right? तो history of viral infection हो गया, तो it will forms in adults while it's polyp. The most common feature of intussusception is abdominal pain, severe pain, vomiting. Okay, and because of this you find a lump. When you do a physical examination of the patient, you will find a sausage or banana like shaped on the stomach of the patient. Okay, He will passing this stool with the red currant jelly stool because of the mixing of the mucosa and the blood. That's why it gives an appearance of the red currant jelly stool. And because what happened, imagination and because of the receiver parts moving upwards and the donator parts moving inwards, then you will found that there is nothing in the right iliac fossa. Cecum is present in the right iliac side. Okay, so then you found nothing in the right iliac side on compression. Then this is known as the sign of dance or Stanley dance. Abdominal X-ray, yes, I keep it for you, that radiological images. Let's see what kind of a sign we are going to see on abdominal X-ray. In interoception, we see meniscus, flat plate. Flat plate means in erect portion. Okay, flat plate. On barium enema, we see Clow sign. Okay, Clow sign or the pincer sign. I will show you. Wait a minute. Okay, I will definitely show you. On sonography, when you do transscan, okay, target sign, bullseye sign, donut sign. You can also see on longitudinal scan, pseudokidney signs. Okay. So what is the treatment? The treatment is like this, that we create a pressure from the per rectum. Then we doing the per rectum. So this is the invaginate part now. So what will happen when we give pressure? These invaginate parts moves outwards and going back against to its normal position. This will be do in 1 to 2 episodes, but when this recurrence happens, then what will we do? We remove that part by the resection and anastomosis with the distal part. Let's see some radiological images. Yes, the sign here you are seeing. Sorry. The sign here are you seeing? This is the pincer sign or the Clow sign. This is the barium enema, right? Barium enema. Why I am saying this? Look at here. This is the rectum, sigmoid colon rectum. This is the descending colon. Okay, only this kind of imagination, which only this part is take up dye and showing image. Okay. The next thing, this is also the pincer sign or the Clow sign. Here you see that this is the meniscus sign or crescent sign. I'm going to see this now. 1/4 of moon-like structure. This is known as crescent sign or okay. Same thing when you go towards the barium enema, you see this is the pincer sign or the Clow sign. Because here we are doing without the barium enema, you see a level of the air fluid level. Okay, this is the air level which is seen, which is trapped here. Okay, this is the air which is trapped here and showing the crescent sign. Wait a minute. क्या हो गया? Sorry for the inconvenience. I need some water. Okay. This is the sonography. Here you can see this. This is the USG image, and this is the target sign or the donut sign. Look how pretty and tempting donut is saying. Okay. Let's going towards the next image. This one is the donut sign and target sign on sonography. This is the target sign. This one is the pseudokidney sign which is seen on the longitudinal scan. This one is the longitudinal scan. This one is the trans scan. Delete it. Next. Okay. Let's again move towards the question. Second is the peptic ulcer. What is happening in the peptic ulcer? There are two types of the ulcers. Wait a minute. Peptic ulcer. There are two types of the peptic ulcer. One is the stomach ulcer and other one is the duodenal ulcers. In stomach ulcer, pain increases on taking food. So here patients will try to keep on fasting. While duodenal ulcer pain increases on fasting. So he needs food all the time, especially junk food, to relieve the pain, and such kind of people become obese, right? मोटे हो जाएंगे, become obese, and these patients, because of the fasting, they will become thick. So we give some antacids and SBS. Okay, let's look towards the next option. Next option is foreign body obstruction. What happened in foreign body obstruction? Usually the round things doesn't cause such kind of a damage to the intestine. It's though there is an easy chance that it will remove through the parectal pathway spontaneously. But when there is a, you see, there is some chances of like someone ingested septic pin. When the septic pin is closed, there is no such kind of an issue that we need to operate it. When this septic pin is open and this is the small pin, when in these two situations we need to operate and remove the foreign body. It can be anything applied like endoscopy, sigmoidoscopy, rectosigmoidoscopy, anything else. Anything can be happen with for the removal of the foreign bodies. Usually for the round and non-harmed bodies, we will wait for the passage with the stool. Last point is the sputomesenteric ischemia and the malrotation. Malrotation is important, but today I'm not going to discuss because it's already a long video and it will take a lots of time of yours. We will discuss it tomorrow. 7 questions. Let's see, because it has an image. That's why we'll look towards first image. What is this? The image is showing that the intestine move upwards and enter into the thorax of the child. Okay, this is the Bogdalex hernia. This one is the Bogdalex hernia. Okay, so this one is the Bogdalex hernia, and let me go towards the question and what he want to ask. He asked that this is the congenital condition and what is the most common cause of the death in the infants. Okay, because it is a congenital, the most common cause of the death is pulmonary hypoplasia, and I'm going to read the options. Cardiac tamponade, no. Coarctation of aorta, no. Diaphragmatic eventration, no. Mediastinal shift, no. It's pulmonary hypoplasia. Why? Because it's congenitally present. Bogdalex hernias is present congenitally, because though it will hinder the development of the lung. Look towards here. You see complete mediastinal shift. The lung here is only this much. You can't see the lung here. This is the only intestinal part. So in such situation, when it is present congenitally, the baby's lungs will not able to develop. When baby's lung not able to develop, how will he respire? Okay, it will leads to the pulmonary hypertension. How will he survive? There is very less chances in the pulmonary hypoplasia to survive by a baby. The most common cause of the pulmonary hypoplasia is oligohydramnios, but here we need to immediate surgery of the patients. And what is the congenital diaphragmatic hernia? Let's see. The congenital diaphragmatic hernia is mainly of two types: Morgagni's hernia and Bogdalex hernia. Bogdalex means back. So you can remember from this, back means present on the lateral aspect. this is your thorax, then this one is the hernia is present from here. Okay, mogagni, remember from this gag, age. Okay, age. In Hindi we say आगे, so you can use this आगे. So mogagni hernia is present in the anterior mediastinum, anterior to the heart. Let's see some images of this. Here you can see this is the intestinal part, this is the heart, this is the vertebrae of the child, and you can say that this is the Mogagni's hernia. Okay, this is the Mogagni's hernia. Here is so beautiful image. You can see this, the whole intestine going upwards, okay, and obstruct the whole lung. Here you can see this is the mediastinal part, heart, and you are not able to see any air shadow. Leads to the pulmonary hypoplasia and increase the risk of death in the newborn. Okay, one more image. Look, this is the liver, this is the stomach part, and this is the intestinal parts moving upwards, compressing the lungs and the heart here. Okay, this one is the Bogdale's hernia. What is going to be happen and why is Bogdale's hernia happens? What is the cause and why this question is asked in the embryology? Look, this is the pleuroperitoneal membrane. What happened? This pleuroperitoneal membrane centrifugally moving inwards and form two parts. Here thorax will develop, here abdomen will going to develop. When this part doesn't fuse, okay, when this part doesn't fuse, it will leads to a formation of the canal known as pleuroperitoneal canal and leads to the Bogdale's hernia. It will leads to the Bogdale's hernia. The surgeon will going to treat it with operation. Done. Okay, let's move towards the 8th question. This question, when I am a student, how I'm going to solve this kind of a question? Okay. So, in this condition, the primary development defects occurs in which portion of the primitive heart related to the embryology of the heart? Option is given: bulbus cordis, cornal septum, left and right horns of the sinus venosus, primitive atria and primitive ventricle, sorry. So look towards the last three lines. Echocardiography is done and it demonstrates that overrides aorta. Overriding of the aorta, my mind says stop. Tautology of Fallets, and tautology of Fallets is due to the cornal septum, and there is no need to read whole question. Okay, let's see. Still we are going to read about the full question. That 5-month-old child turning blue suggestive of the cyanotic heart disease, cyanotic weak dyspneic, similar episodes. She has facing similar episodes in the past but never this serious, because he is Indian parents have some kind of an issue that when the condition becomes severe, then they were brought to the uh, doctor. Not even with parents, everyone has same kind of a nature that maybe there is no such necessary. So when the condition becomes severe, they will run toward the hospital, and this is situation is towards the same here with this child. Okay, when cardiac examination is done, normal S1, normal S, single S2, and a grade 3 systolic murmur. Grade 3 systolic murmur present है, cyanotic heart disease present है, तो it is suggesting of the cyanotic heart disease. एक second, let's learn about this. Wait a minute. What will going to be happen during the development of the heart? During the development of the heart, look at here. Okay? Look at here. First, these are the two tubes. These are the two tubes which are going to form in the starting, and these are trying to fuse. But these are fusing like this. That upper two remain separate and the lower two remain separate. Here, these two fuses. Okay, and this will remain separated. This is the blue part showing up forming sinus venosum, and look at the upper part. चलो okay. So this one is the bulbous cordis, primitive ventricle, then primitive atrium, and this one form the sinus venosum, which carries the blood from the other parts and the heart. And what happens when this swellings, bulging like a structure will form, bulging like a structure is formed, divides it into the 4 parts, and what happened, this tube will going move folding towards, ठीक है, fold होगी, फिर तो बीच में से fold होना start होगी, and it will form the ventricle and the atrium. Here the heart is formed now. Wait a minute. गर्मी है भाई. Okay. Let's read it from here. ठीक है. This is the congenital heart disease is divided into two. That is cyanotic and the acyanotic. Cyanotic and the acyanotic is given. Then acyanotic is of further type, that is acyanotic. Atrial septal defect, ventricular septal defect, patent ductus arteriosus, endocardial cushion defects. And when cyanotic heart disease is divided into further 2 types depending on the pulmonary blood flow. So it's TOF, which is the most common cyanotic heart disease. I already told you in the last video that examiner will ask about the most common things, not about the rarest thing, and he don't want to be confused a lot. Okay, he will ask about the most common, because these are the basic routine in which we see the cases. According to the cases is seen, mainly the question arises from that, not from the rarer aspect. TOF, tricuspid atresia, transposition of great arteries, total anomalous pulmonary venous congestion, truncus arteriosus. Okay, these are the part. What is happening in the top? Let's see by the image. Look here, this is the normal heart. This one is the normal heart. This one is the tetraros of paratology heart. Okay, this one is the normal. This is the TOF heart. Here you can see this one is the right ventricle, but when you are going to say this is the right ventricle, the cavity of the right ventricle becomes smaller, and it will lead to the right ventricle hypertrophy. This has happened because of the pulmonary stenosis. Pulmonary stenosis makes the cavity small and increase the pressure in the right side of the heart. overriding of the aorta and the ventricular septal defect. Why ventricular septal defect? Because it's about the nature's art. It's give a way of the survival. When the pressure will increase in the right ventricular, and because of the pulmonary stenosis, the blood not able to reach. The blood will not able to reach in the body. So what will going to happen? There will be defect. So that blood will blood will reach to the left ventricle and reach to the entire body. Okay. This is the tetraps of politology, and why this happened? Because of the defect in the choanal septum. Let's read about this choanal septum. Usually the choanal septum is in this spiral form and gives rise, one side gives the abdominal ascending aorta and one side gives to the pulmonary trunk. When due to anyhow reason this spiral septum not form spiral and become straight, तो what going to happen? पहले क्या था? Before the abdominal, the ascending aorta is present here and pulmonary trunk is present here. अब now no more spiralation of the septum and it will leads to the pulmonary trunk to here and the ascending aorta here. So what going to happen? This will form transposition of the great arteries, because the normal the position is going to be changed. This is our heart. So usually from this pulmonary trunk and from this ascending aorta arises. Now what going to be happen now? This is the right ventricle and from here ascending aorta will going to rise, and this one is the left ventricle. From here pulmonary trunk going to arise. Okay, so this one is because of the non-spiralation of the choanal septum. Now what happen when spiralation will occur? Definitely spiralation will happen, but it leads to the shifted towards one side, towards a pulmonary trunk, and this one is the ascending aorta. What going to happen? It will leads to the stenosis, leads to the right ventricular hypertrophy, and because of an overriding of the aorta, and because of this right ventricular hypertrophy, we need a defect, that is VSD, so that blood supply will continue. This is the reason that TOF occurs due to the positional defect in the choanal septum. The choanal septum will move downwards towards the pulmonary trunk, and it will leads to the pulmonary stenosis and overriding of the aorta. Let's clean out here. Let's have some images, most important images regarding the congenital heart disease. Look at from the option first, then we will going to look at. The first option was that coarctation of the aorta. अच्छा ये रह गया था, sorry. These images of this question we will going to do later. First we are going to do images of trunk tetraps of phallatology and all. In TGA, the heart is found as egg on the string appearance. Look at here. Let's me remove my image first. It's here. Okay. This is the heart, egg like structure as like image is showing, and this one is the string. So in TGA, for in TGA, agon like string appearance. तो इसको we will going to remember from this TG. G means hair egg. Okay, egg on string. In both two words we have find that G is present. That's why we will learn from this that in TGA egg on string appearance is present. ठीक है. This is the image of the top tautology of phallus. This is due to the defect in the choanal septation. Shifting choanal septum will shift towards the pulmonary trunk, and this here look foot-like structure. This is how it's look in top. Look at here. TOF. When I'm going to read from last word to first word, I can read from here is like this foot, or I can read it like this foot. Okay, foot. So corne sobet, we are going to say this is corne sobet, boot like structure. Okay, so what we wear in the foot, we wear boot, foot and the boot. We are wearing boot, so we can say that the boot like structure is seen in the top, corne sobe like structure is seen in the X-ray on the top. Okay, these two images are taken in this area. Other one image is here. This one is this cute snowman. Hannah, snowman. You can see this. This is the figure of 8 appearance and the snowman like appearance too. When you see here, what is here happens? Abnormal connections. This abnormal connection is seen in TAPVC. Okay, this abnormal connection is seen in the TAPVC, where you are seeing that TAPVC is of 3 types. Abnormal connection you can see of the SVC. It can be at the level of heart, above the level of the heart, and below the level of the heart. Let's going to back to the question. Question number 9. Spermatogenesis related question is asking, because I saw the first word. Let's see, but what he is going to ask, that amount of DNA and the number of chromosomes, which cells. So let's see last 2 to 3 lines. He focused on a group of the cell that recently gained on acrosome and the tail. So the chromosomal material is taken from the acrosomes. And during spermatogenesis and acrosomes in the sperm containing a haploid set. For the haploid we used N. There are 2 options related N, but what happened? We are dividing the number of chromosomes. We are dividing the number of the chromosomes and from 46 to 23, and so that the answer will become 23(1)N. Let's see about the spermatogenesis process. This is the acrosome here, and you see the nucleus. That's why I'm taking some image that acrosome contains the nucleus and the body is containing the mitochondrial part. Here is spermatogenesis. Look at here. Spermatogenesis is started from the spermatogonium, which is an 2N diploid structure, which due to the mitotic division it will convert into primary spermatocytes. Which is a 2N structure. From here meiosis is going to start, meiosis 1 and the meiosis 2. This one will leads to the independent assortment ठीक है. It will leads to the independent assortment. अरे यार, this question is asked once that it is independent assortment. After meiosis 1 and the meiosis 2, we get the n number of the chromosome, that is haploid number of the chromosomes. What is going further, that this will going to form after the meiosis 2, it will form the spermatids. Second spermatocytes will form second spermatocytes. After second spermatocytes, spermatids will form. After spermatids, spermiogenesis happens, which will lead to the formation of the spermatozoa, which will go towards the epididymis and forming a motile-like structure and forming a spermatozoa. After the spermiation, it will move outside the body with the help of the ejaculation. Okay. This one is little bit boring, no? Okay, fine, but it's okay. We have to learn this again. Spermatogonium, mitotic division, primary spermatocyte, and then second spermatocyte. After the meiosis first, after meiosis second spermatocyte will lead the formation of the spermatids, and after spermatids, with the help of the spermiogenesis, spermatozoa will going to be formed. Let's look towards the last question. Because it's 2 to 3 line questions, we have to read the entire question from the starting. During embryonic period, urinary system, a portion of the bladder, a portion of the bladder extends into the umbilical cord, that is urachus. Failure of this vestigial, and that is urachus is unable to degenerate. When urachus is unable to degenerate, what will going to be happen? Few things will going to be happen, that it can leads to the formation of the urachal fistula. This one is the urachal fistula. Okay, this one is the urachal fistula, which you can see this, there is 2 opening here. This one is the urachal sinus. Sinus means the blind ending. This one is the blind end, and this one is the one opening. This is sinus. This is the normal thing, right? This one is the normal, that it forms the ligament, median umbilical ligament. Okay, this urachus will form the median umbilical ligament, and here you can see this is the swelling part which is going to form a cyst-like structure. Okay. To here you can see this, that he's saying a portion of the bladder extend, only a portion, not the whole portion. Maybe it can be a cyst, most probably it's saying that cyst. And what it's going to be formed, the bladder extrophy. No, bladder extrophy में क्या होता है, anterior abdominal wall defect होता है. This is the image of the bladder extrophy. Let's see first. This is the image of the bladder extrophy, where bladder is present outside, and there will be defect in the urogenital system also. Second option is adenocarcinoma. Yes, this is the correct statement, because when there will be the cyst, there will be the secretion, and the secretion will from the glands, and the glands was used for adeno. It will lead to the adenocarcinoma. Macus diverticulum we already had done, that it is derived from the omphallomesenteric duct remnant. Polycystic kidney disease, no, not due to the polycystic disease, but it is not the part of the urachus. Okay, it is from the metanephrons. Renal agenesis because of the non-development of the metanephrons, which forms the kidney part. Sorry. Metanephrons. I'm right, from the metanephrons. Okay, these are the 5 questions which we had done today. Let's revise in few minutes. Start from the 6th question. The sixth question is about the Meckel's diverticulum. Meckel's diverticulum is a true diverticulum. Rule of 2 is more important. Less than 2 year, most commonly in the male, 2 inch in length, 2 feet proximal to the ileocecal junction. We need to do diverticulectomy and or resection and anastomosis. Two types of mucosa is present: pancreatic colon or gastric mucosa. Gastric mucosa will leads to the bleeding and the perforations. ठीक है, intussusception, red currant jelly stool. Seventh question is about the Bogdalen's hernia, which leads to the pulmonary hyperplasia in the child and leads to the increased risk of the survival of the patient. We needs to immediate surgery. Bogdalen's hernia is due to the remnant of the pleuroperitoneal canal, and the intestine will move towards in the thoracic part. Eighth question is about the congenital heart disease in the tetralogy of the pallets. Tetralogy of pallets means 4 things which I have to remember. In the top, over resembles overriding of the aorta. Pulmonary stenosis which leads to the right ventricular hypertrophy and ventricular septal defect because we need the flow of the blood. This is happened due to the defect in the coronal septum because the coronal septum moves downwards toward the pulmonary trunk. The next question is the spermatogenesis. Spermatogenesis, what will going to happen? Spermatocytes, primary spermatocytes, secondary spermatocytes, spermatids, and then the spermatozoa going to be formed. And it is haploid and 23 chromosome containing structure. The last one is about the urachal cyst. During the formation of the bladder, the urachus becomes remnant. When it becomes remnant, it can be present as a fistula, it can be present as the sinus, and it can be present as the cyst. And in cyst, there is increased chances of the adenocarcinoma, and that's why it will lead to the bladder adenocarcinoma. So today's session is over. Don't forget to like, share, subscribe, and read these topics again by yourself. And I will try to speak almost in English. Hope you will like it and enjoy the session. Thank you.